I want everyone to imagine that they are driving a loved one to the hospital. And on the way, you have to pull over to the side of the road as an ambulance whizzes by you, bringing a patient who is in critical condition to the very same hospital. Both patients are admitted, and you sit down in the waiting room, calm and collected, and open your book to pass the time. On the other end of the hospital, the other patient's family is riddled with anxiety. Those what-ifs are swarming around in their head. Both patients simultaneously receive a central line. This is a central venous catheter that is inserted at the point of that needle and travels down that blue vessel, known as the internal jugular vein, and into the heart. Your loved one requires internal values within their heart to be measured, whereas that other patient requires blood and drug delivery just to keep them alive. So page after page of your book goes by, chapter after chapter, until you find yourself face to face with a doctor who says to you, "I am so sorry. We did everything that we could." Meanwhile, on the other end of the hospital, the other patient's family is celebrating, as they've just received news that their loved one is completely stable and is going to make a full recovery. The situation of your loved one is the unfortunate reality for up to 15% of patients who receive a central line. And this is the case despite the fact that ultrasound guidance is the standard of care in Canada. The clinicians are still unable to distinguish the needle tip from any other point along the shaft of that needle, meaning the depth of that needle is still unknown. This is where our research fits in. We aim to make use of all of the technologies available today, from tracking technologies so that the location of that needle is known, to head-mounted displays so that we can bring all of this information into a single field of view in front of the clinician's eyes. We aim to bring sight to surgery so that those what-ifs can be completely erased from everyone's mind, and so that the depth of that needle is now known to the clinician, so that the instance that causes that death, where that carotid artery, that red vessel that sits just next to that internal jugular vein, no longer gets punctured and no longer results in patient death. So that we can allow clinicians to have all of the sight and remove the skin as a barrier of sight, so that we allow them to have the full potential of that surgery. And so that those what-ifs and the question of if that patient will return home with the same loved one that brought them to the hospital is erased from everyone's mind, and that the clinician is able to do what they do best, complete the operation. And so I'm gonna end my talk here by asking you, if this were you or your loved one, which side of the slide would you choose? Thank you.